Guideline. Acute coronary syndrome is an umbrella term for symptoms caused due to thrombosis of the coronary arteries. It can represent unstable angina, where patients have worsening or new chest discomfort without any EKG, evidence of a STEMI, and no troponin elevation. It can represent NSTEMI, where there is elevation of troponin, and STEMI, where there is elevation of EKG. Several historical milestones are important to remember. The pathogenesis of atherosclerosis and thrombosis. This occurred in the early 1900s. The thrombus hypothesis, which happened in the 1980s. All of these led to evolution in myocardial infarction management and use of different strategies. In the early 1900s, pathogenesis of atherosclerosis was investigated using a rabbit model. In this model, the rabbit was fed animal protein. The hypothesis of the gentleman conducting the research was that animal protein causes the plaque, and he showed that feeding the rabbit animal protein did indeed cause formation of plaques. This was subsequently refined where the rabbit was fed cholesterol, and it was proven that cholesterol caused the plaque, and this led to the lipid theory of atherosclerosis. Ignowski in 1908 did the initial experiments. 5 short years later, Antikov showed that cholesterol was the cause of the plaque by feeding the rabbits different things. Ultimately, cholesterol itself caused the plaque formation. Further research later as to why stable plaque became unstable and gave heart attacks revealed that plaque rupture caused more than 70% of the thrombi. Plaque erosion, hemorrhage into the plaque, etc. were also responsible. This led to the idea of plaque rupture causing 75% of the thrombi. This occurs in thin-walled atheromas, and a vulnerable plaque came to be defined, which is full of a large lipid core and inflamed fibrous cap, which is thin. When that ruptures, subendothelial tissue is exposed. That leads to the thrombus formation, which can be occlusive or non-occlusive. Prior to 1980, the dominant theory of a heart attack was that it is caused by an unclear, possibly vasospasm or progression of the atherosclerotic plaque, and the thrombus occurred later. Key studies to determine this included coronary angiography, carried out within hours of a heart attack by Dr. D. Wood, and he showed that a majority of the heart attacks were indeed caused by thrombus, and the thrombus outcome determines the event. If coronary spasm were the primary cause, early in the heart attack, you would not expect to see a thrombus, but D. Wood et al. Showed that early in the heart attack, more patients had thrombi than later patients. Therefore, the heart attack was caused by the thrombus. Subsequent researchers confirmed this, and at the end of the day, as a result of D. Wood, Sherry, and Rentrop studies, there was confirmation that thrombus actually is the pathophysiology of a heart attack. As a result of this pioneering work, subsequent understanding led to the development of streptokinase to cause intravenous thrombolysis. This development is also very interesting. The gentleman who found streptokinase found it incidentally when bottles he left with streptococcus in it was shown to have cleared up human serum, and then he identified streptokinase.
You know, for the longest time, it was one of the biggest mysteries in all of medicine. This sudden, catastrophic event that could strike anyone, seemingly out of nowhere, leaving doctors and families with just one agonizing question: why? Well, today, we're cracking the code of that killer. This is the story of the heart attack and the incredible scientific detectives who pieced it all together.
So let's just start with the big one, the central question that took the better part of a century to answer. What is actually happening inside our arteries during those critical life or death moments? For so long, the answer was, well, it was pretty blurry.
Okay, so let's get the official term out of the way. It's called a myocardial infarction. Sounds complicated, right? But all it really means is death of heart muscle. Your heart is a muscle, and just like any other muscle in your body, it needs a constant supply of blood and oxygen to work. When that supply line gets cut off, the tissue starts to die. That's the heart attack. The real mystery was, what's causing the blockage? And you have to understand, the stakes were unbelievably high. For most of the 20th century, a heart attack was basically a death sentence. Doctors were pretty much helpless, and the real cause was often only figured out on the autopsy table, which of course was way too late. Our detective story really begins in a super unlikely place, a lab in St. Petersburg, Russia. And the scientist who found the first clue wasn't even looking for the cause of heart disease. He was about to stumble onto a massive piece of evidence completely by accident. So, this is the guy, Alexander Ignatowski. It's 1908, and he's investigating something he thinks is a totally different problem. But the work he's about to do will, without him knowing it, lay the foundation for everything we understand today. But here's the really wild part. His main idea was completely wrong. He was convinced that the gunk that builds up in arteries, what we call atherosclerosis, was caused by some kind of poison in animal protein. He literally thought he was studying protein poisoning. So his experiment was honestly incredibly simple. He took a bunch of rabbits, which are natural herbivores, they only eat plants, and he started feeding them a diet packed with meat, milk, and eggs. And the results? Well, they were absolutely stunning. The rabbits developed these massive fatty plaques in their arteries, just like the ones you'd see in humans with severe heart disease. He had figured out how to create the disease on demand. In this picture, kind of gives you a feel for the world where all this was happening. Ignatowski would go on to teach and run places just like this, and his accidental discovery slowly started to send ripples through the entire medical community. Okay, so Ignatowski's onto something. He's found a link between an animal diet and clogged arteries, but he's still blaming the wrong part of the food. So the next generation of scientists took his work and started to zoom in to try and pinpoint the real culprit. And you know what's crazy? The next piece of the puzzle fell into place incredibly fast. We're talking just 5 years after Ignatowski's paper, another Russian scientist, Nikolai Anichkov, decides he's going to get to the bottom of this. So Anichkov starts testing all the different parts of the diet. Is it the protein, like Ignatowski thought? Nope. Is it the fat? Getting warmer. Then he has a brilliant idea. He feeds the rabbits pure, isolated cholesterol. Just cholesterol, and bingo, that was it. He found the single molecule responsible for building those dangerous plaques. And just like that, this one experiment created what we now call the lipid hypothesis, the core idea that cholesterol in our blood is a primary cause of atherosclerosis. It's the scientific foundation for every single cholesterol-lowering medication we have today. All right, so we've got the plaque buildup figured out, but that's a slow burn, a chronic process that takes decades. What about the heart attack itself? That sudden, terrifying moment? Well, this question led to the next great debate in cardiology, and this one raged for half a century. So here was the debate. Is a blood clot the cause of the heart attack? Does it form first and block the artery? Or does the heart muscle die for some other mysterious reason, and then a blood clot forms in the stagnant blood as a consequence? And this wasn't just an academic question, right? The answer would completely change how you treat someone. That 50-year debate was finally settled in 1980, and it was settled by this one powerful number, 87%. So where does this number come from? A doctor named Marcus de Gutwood, who did something that was frankly kind of crazy at the time. He started taking patients who were in the middle of having a heart attack and rushing them to the cardiac cath lab to take an X-ray of their arteries. And what he found was that a staggering 87% of them had a total blockage from a blood clot within the first 4 hours. This was the smoking gun. The clot wasn't a consequence, it was the cause. And to what's work gave birth to this incredibly powerful phrase, one that every paramedic, every ER doctor knows by heart: time is muscle. Every single minute that artery stays blocked, more of the heart muscle dies. This one idea created the entire field of emergency angioplasty and clot-busting drugs that save millions of lives. Okay, so we've got our long-term villain, cholesterol plaque. We've got our immediate trigger, the blood clot. But there was still one last piece of the puzzle missing.
Why do some plaques just sit there for decades, causing no trouble, while others suddenly explode and trigger a deadly clot?
The answer to that came from the painstaking autopsy work of Dr. Erling Falk. She's the one who discovered that not all plaques are created equal. The really dangerous ones, the ones he called vulnerable plaques, they have a specific structure. This big, soft, fatty core, covered by a really thin, fragile, and inflamed cap. It's basically a ticking time bomb. So here it is, the whole tragic sequence, step by step. First, that vulnerable plaque develops. Then, its thin little cap suddenly tears open. This exposes all that fatty gunk inside to the bloodstream, and the body's clotting system just goes into a panic. It forms a massive clot almost instantly, and boom, the artery's blocked. That is the anatomy of a heart attack.
And this is so important, because what Falk's work did was completely change the game. It wasn't just about the clot anymore. It was about understanding the unstable plaque underneath it. This insight changed everything about prevention, because now we knew we had to stabilize those dangerous plaques, not just worry about the clot. So let's just step back and put this all together. This century-long investigation, from those labs in Russia with rabbits to American cath labs in the middle of the night, every single one of these breakthroughs led directly to the tools doctors use right now to fight this killer disease. I mean, look at this. You can draw a straight line from each of these pioneers to the treatments that save lives every single day. Ennikoff's discovery about cholesterol, that gave us statins. DeWood's time as muscle breakthrough, that's why we have emergency angioplasty. Falk's work on vulnerable plaques, that's why millions of people take antiplatelet drugs like aspirin. Each person solved a critical piece of the puzzle, and their solution became a modern therapy.
So for 100 years, we've gotten really, really good at treating the attack, at diffusing the bomb after the countdown has already started. But this whole journey brings us to one final, huge question. Now that we understand the killer's entire playbook, from start to finish, is the next great frontier not just getting better at treating the attack, but preventing that very first plaque from ever forming in the first place?
Therefore, it became clear that if you have a mural thrombus that allows blood flow to go through, you get unstable angina. If you have an occlusive thrombus, which causes a total blockage and damage of the muscle downstream, you have an acute heart attack or sudden death. Sudden death often occurs because of heart rhythm disturbances. In the early 70s, when there wasn't a clear understanding of the pathophysiology, management of a heart attack was conservative. People were given bed rest, and subsequently they died of the heart attacks. Later, ICUs were formed with monitoring and resuscitation strategies, and then once the thrombus theory was understood, reperfusion strategies came in. 1950 saw the development of external defibrillators. In 1965, portable defibrillators were used for ambulance use. Once the importance of opening the artery was realized, in the 90s initially, the majority of the centers practiced thrombolysis. Then Cindy Grimes and a group out of Beaumont Hospital came up with a primary angioplasty trial that showed superiority of primary angioplasty, leading to percutaneous intervention and stents for acute coronary syndromes. At any rate, the standard of care is rapid reperfusion. Whether the reperfusion is achieved by cardiac catheterization and stent implantation or thrombolytics depends on local availability.
Today, we're going to dive into one of the most important stories in modern medicine. Seriously. It's about a series of clinical trials, the ACS trials, that just sliced through decades of confusion and totally changed how we treat heart attacks. It's an incredible story about how they did it and how it saved countless lives. So let's get right into it.
Okay, so I want you to picture this. It's the early 1980s. You're being rushed to the hospital. You're having a heart attack. Your life is literally on the line. The doctors around you, they're brilliant, they're dedicated, but they're facing this massive question. Out of all the possible treatments, which ones actually work? And how can they be sure?
And here's the tough part. They really couldn't be. The truth is, medical research back then was, well, it was a mess. It was this tangled web of dozens of small studies, each one with its own complicated setup, and to make it worse, they were constantly contradicted each other. So if you're a doctor trying to make a split-second life or death decision, that kind of evidence is more confusing than it is helpful. And this slide really shows you just how bad that confusion was. Let's take clot-busting drugs, a super promising idea. By the mid-80s, 24 different trials had looked at them, but the results were all over the place. Only 5 showed a clear benefit, 11 kind of hinted at one, but the results weren't strong enough to be sure. And get this, 8 of them actually suggested the treatment might be harmful. This is what scientists call statistical noise. It's like trying to hear a single voice in a roaring crowd. With so many small studies, you get this blizzard of conflicting data that makes it impossible to see what's actually true.
So, faced with this wall of noise, a group of researchers at the University of Oxford came up with a new plan. It was an idea so simple, yet so powerful, that it would completely change how we answer big medical questions forever. They called it the Large and Simple Trial. And the logic? It was just brilliant. The thinking went something like this. Instead of studying a few hundred perfect, hand-picked patients in some pristine lab setting, why not study tens of thousands of regular, real-world patients in everyday hospitals? And instead of a super complicated protocol with tons of data points, why not make it so simple that any busy doctor anywhere could easily take part? The idea was that the sheer size of the trial would be enough to drown out all that statistical noise and give them a clear, undeniable answer.
And you can see the difference right here, plain as day. The old way, traditional trials, they were small, expensive, and really picky. They'd often exclude older folks or people with other health issues. This meant their results, even if they were clear, didn't always apply to your average person having a heart attack. The large and simple trial idea, it just flipped the whole thing on its head. We're talking massive scale, real-world patients, and dead simple protocols. All of it designed for one thing, get a clear answer that doctors could actually trust and use right away. So the first big test drive for this idea was the ISIS-1 trial, which ran from 81 to 85. They tested a common drug called a beta blocker, atenolol. Now the scale was just unheard of at the time, over 16,000 patients, and the result was exactly what they'd hoped for, a clear, undeniable 15% reduction in deaths from heart-related issues. What's crazy is that a smaller trial had found almost the same effect, but because it was so small, nobody could be sure if it was real or just chance. ISIS-1 proved it. Size mattered. The method worked.
Okay, so with the success of ISIS-1, that was kind of the opening act. The stage was now set for the main event. An even bigger, even more ambitious study called ISIS-2. This was the trial that would truly change the world. Just look at that number. Almost 17,200 patients enrolled in just a couple of years. And again, this wasn't just happening at a few fancy universities, no. This was happening at 417 normal hospitals in countries all over the globe. That proved that the simple part of the design was just as important as the large part.
And the design of the trial was just beautiful, so efficient. They used what's called a 2x2 factorial design, which is just a clever way of asking 2 big questions at the same time. Patients were randomly put into one of 4 groups. They either got the clot buster, streptokinase, or a placebo. And at the same time, they got either a daily aspirin or a placebo pill. This genius setup let the researchers test not only each drug by itself, but also what happened when you used them together. It was basically like running 2 massive trials for the price of one.
So you've got over 17,000 patients, this incredibly elegant design, and the medical world was about to get a definitive answer on 2 super promising and super cheap treatments. And the results, when they were published in 1988, were absolutely stunning.
First up, streptokinase. Take a look at this graph from the original study. The top line is the death rate for patients who got the placebo, and the bottom line is for those who got the drug. You see how they split apart almost right away and just keep getting wider? That's what a life-saving treatment looks like in data form. It reduced the risk of dying by a massive 25%. The debate was just over. Then you have aspirin. The results were just as mind-blowing. You see the exact same pattern. Patients who got a simple, cheap aspirin every day saw their risk of dying drop by 23%. This was a total revelation. I mean, this common thing you have in your medicine cabinet was actually a powerhouse, life-saving drug for one of the biggest killers on the planet.
But here, this is where it gets really incredible. What happened when you gave patients both treatments? Just look at the split in this third graph. It is way wider, way more dramatic than either drug on its own. They weren't just working separately, they were working together, creating an effect that was even more powerful.
The combined effect was a 42% reduction in the risk of death. I mean, just let that sink in for a second. By combining two cheap, widely available drugs, doctors could almost cut the short-term death rate from a heart attack in half. To put that in perspective, for every 1,000 patients treated this way, somewhere around 40 or 50 people who would have died were now going home to their families. This was a quantum leap forward in cardiac care.
So, what happened next? Well, the results of ISIS-2 weren't just some dusty finding in a medical journal. No way. They sent shockwaves through the entire medical community and created a legacy that's still saving lives today.
You know, the researchers themselves put it perfectly. They said the findings transformed clinical practice worldwide. And that's not an exaggeration. The evidence was just so clear, so undeniable, that ERs all over the globe were rewriting their treatment plans almost overnight.
So the takeaways here are just huge. First, aspirin became a go-to, standard treatment for heart attacks, a practice that's still essential today. Second, the trial brought absolute clarity, ending decades of arguments with one powerful set of data. Third, and this might be the biggest one, it proved that the large, simple trial method was the real deal, a powerful new tool to solve medicine's biggest questions. And finally, the impact was immediate. You didn't need some new expensive machine. The life-saving drugs were already on the shelf, ready to go.
And that brings us to a final thought. The story of ISIS-2, it's more than just a history lesson. It's a really powerful reminder to stay humble. It forces us to ask a tough question. If a trial this straightforward could totally rewrite medicine back in the 80s, what things that we think are certain today might be resting on a much shakier foundation than we realize? What's the next big truth, just waiting for the right large, simple trial to come along and show us the real answer?
Following the common adage, time is muscle, triage is time. Once someone presents to the emergency room with a chest pain syndrome, they should undergo assessment with an EKG within 10 minutes. If thrombolytics are being administered, needle to thrombolytic time or door to needle time, as I say, should be 30 minutes. If it's PCI, door to balloon time should be 90 minutes. If we're being transferred, then diagnosis to reintervention or balloon time should be less than 120 minutes. Aspirin should be given in a loading dose. It should be chewed and swallowed. Dose should be 160 to 325 milligram. Delayed action aspirin should not be used. Enteric-coated aspirin should not be used. Mechanism of action of aspirin, it works by inhibiting cyclooxygenase. It reduces platelet antagonist thromboxane 2, and it is irreversible. Clinical evidence for benefit of aspirin comes from the ISIS-2 trial, which had more than 17,000 patients. Monotherapy reduced 5-week cardiovascular mortality by 23%. In combination with streptokinase, mortality was reduced by 42%. It reduced subsequent non-fatal heart attacks, and the benefits lasted up to 10 years. The ISIS trials also showed benefit of beta blockers. Recommendations are to use a beta blocker unless contraindicated. Contraindications include cardiogenic shock, acute pulmonary edema, high degree AV block, or severe COPD. The beta blocker used should lower the heart rate less than 60 while keeping the systolic blood pressure more than 100. Plavix is often used, and it should be remembered that Plavix is a prodrug, requires activation. There are several people who have Plavix resistance. After absorption, Plavix requires activation by CYP2C19. The active metabolite is irreversibly bound to the P2Y2 Y12 receptor, and it has delayed action, it has modest inhibition, it is variable from person to person, and Plavix resistance is defined as less than 10% decrease in platelet aggregation. People have genetic polymorphisms, in particular CYP2C19, 2, 3, 4, and 5 loss of function alleles, where they do not metabolize Plavix. The risk could be stent thrombosis, recurrent cardiovascular events, and there are genetic tests available for this. In addition to genetic tests, there are other factors like platelet turnover, P2Y12 upregulation, Clinical factors including age, BMI, chronic kidney disease, diabetes, and drug interactions that can impact Plavix efficacy. This led to the development of better drugs such as tricalagor. Mechanism is reversible inhibition of P2Y12. It is more potent and gives more consistent inhibition than Plavix. The trial data from Plato showed clearly this is superior to Plavix with regards to cardiovascular death, MI, and stroke. There was increased bleeding incidence. Real-world data also confirms this, and it can be used instead of Plavix, particularly if patients have had prior stent thrombosis. We are quite familiar with DAP therapy. However, nowadays we have several patients with AFib who are also on DOACs. When patients are on triple therapy like that, it is recommended to drop the aspirin at 1 month, continue with the Eliquis and, for example, the Plavix. With regards to interventional strategies, timing is of the essence. For PCIs, comparing radial access to femoral access, radial access is superior. Percutaneous intervention nowadays implies stent implantation. However, the original definition was minimally invasive, non-surgical procedure. It treats narrowing of the coronary arteries. It was pioneered by Dr. Drunzig, who treated an index patient with proximal LAD with a balloon. At that time, balloons and stents were used for peripheral vascular work. Now, PCI is synonymous with coronary angioplasty with stent implantation. PCI commonly involves access via peripheral artery, either radial or femoral, fluoroscopic imaging, use of contrast dye to delineate the coronary arteries, restoring the blood flow by passing a wire across the lesion, inflating the balloon, crushing the plaque, and subsequently implanting the stent. Timing is critical, and door to balloon time should be less than 90 minutes. With regards to stents, you have several different kinds: bare metal stents, drug-eluting stents, bioabsorbable stents. The drug-eluting stents are coated by sirolimus, for example. In addition, when stents are being implanted, debulking strategies such as rotational, orbital, or laser atherectomy or coronary intravascular lithotripsy can be used to modify the lesion. Stent-related issues include in-stent restenosis, stent thrombosis, incomplete stent apposition, and a lot of these are nowadays mitigated by, for example, intravascular ultrasound or OCT technologies to visualize at the time of stent implant. Comparing radial to femoral access and comparing traditional radial access to distal radial access, several trials have shown superiority of radial access, in particular distal radial access. Distal radial access is a more difficult technique and may consume time, and this should be kept in mind.
When a heart attack hits, it is an absolute race against the clock. The heart muscle is literally being starved of blood, and every single second matters. So today, we're going to go deep inside the arteries to see exactly how doctors fight back, how they clear that blockage, and how they get the blood flowing again. We're going to explore how modern medicine is really turning the tide in this critical life or death battle.
Okay, so picture this. You're having a heart attack. You've made it to the hospital. The clock is ticking loudly. The decisions and the procedures that are about to happen mean they're going to define everything. So what's the game plan? What happens right now?
All right, first things first. We have to understand the enemy. You know, a heart attack isn't just the heart suddenly failing out of nowhere. It's really a plumbing problem. A critical pipe, an artery that feeds the heart, has become completely 100% blocked.
And this image right here, this shows you the problem perfectly. What you're looking at is a coronary angiogram. Think of it like an X-ray roadmap of the heart's arteries. And you see that spot where the road just stops? That's it. That's the blockage. Blood is hitting a dead end, and that is what's causing the heart attack.
Now, in the medical world, this whole emergency falls under one big term: acute coronary syndrome, or just ACS. It's the catch-all phrase for any time blood flow to the heart gets suddenly cut off. And the mission? Well, it couldn't be simpler. Unblock it. Fast.
So how do they do that? The modern solution is this incredible procedure called percutaneous coronary intervention, or PCI. This is the non-surgical, minimally invasive technique that has totally revolutionized how we treat heart attacks. This is the main event.
Okay, so to pull off a PCI, doctors have to get their tools from outside your body all the way into these tiny, delicate arteries of the heart. And the very first decision they have to make is which route to take. What's the best on-ramp to the body's arterial superhighway? For the longest time, the standard way in was through the femoral artery, way up in the groin. But as huge clinical trials like Rival and Matrix have shown us, going in through the wrist, the radial artery, is just plain safer. We're talking way fewer bleeding complications. And get this, in heart attack patients, it's actually linked to lower mortality. That evidence has caused a massive shift in how this is done. The wrist is now the go-to entry point for almost everyone.
And what's so fascinating is how science just keeps getting better and better. Even within the wrist, there's a new debate: the standard spot or this newer, more distal entry point, closer to the hand. This distal approach seems to be even better at preventing complications, like a hematoma, which is basically a nasty deep bruise, or even the artery getting blocked off later. So what's the catch? Well, it's a smaller target, it's trickier to hit, and it can take a bit longer. And time, as we know, is everything during a heart attack.
All right, so the team has their access point. Now the real work begins. Let's follow that catheter as it makes its journey to the heart and see exactly how they take care of that blockage.
It all really boils down to these three pretty elegant steps. First, an incredibly thin guide wire is carefully threaded right through the blockage. It's amazing. Second, a tiny little balloon is sent over that wire and inflated. That inflation just squishes the plaque flat against the artery walls, reopening the channel. And finally, a stent. This little wire mesh tube is put in place and expanded. It acts like a permanent scaffold to prop the artery open for good.
And these stents, they are just marvels of engineering. The first ones were just simple bare metal scaffolds, but today's standard is the drug-eluting stent, or DES. This thing is brilliant. It's coated with a medication that slowly releases over time to stop scar tissue from growing back inside the artery. It dramatically lowers the chance that the artery will ever get blocked again.
So the plumbing is fixed, the mechanical part is done, but a whole new battle is just starting, the biological one. The body sees this new metal stent as an injury, and it immediately wants to form a blood clot on it. And stopping that clot, well, that's the next critical mission.
And this is where the medication comes in. The absolute cornerstone of post-procedure care is something called dual antiplatelet therapy, DAPT for short. Think of it as a 1-2 punch. It's usually aspirin plus another drug, like clopidogrel. And together, they make your blood platelets less sticky, preventing a dangerous clot from forming on that brand new stent.
So this leads to a pretty logical question, right? It's a question doctors started asking themselves. If two of these drugs are good, wouldn't adding a third, even more powerful one, be even better? Could a triple therapy save even more lives?
Well, you know what? Science put it to the test with the practice trial. They took two groups of patients. One got the standard 2-drug therapy, DAPT. The other group got DAPT plus a really potent third drug. And the results? They were crystal clear. The main outcome, which was a mix of death, another heart attack, or needing another urgent procedure, was almost exactly the same in both groups. This is what we call a negative trial, and it is so important. It proved that in this case, more was not better, and it stopped doctors from giving patients a risky drug that offered no extra benefit.
So, we have this incredible, life-saving procedure. It's amazing. But how does it actually work in the real world? Having the tech is one thing, but making sure every patient who needs it actually gets it, that is a whole different challenge. And this number? This one's a bit of a shocker. It tells a tough story. Only about a quarter, just 25% of hospitals in the United States are actually equipped to perform a PCI. This creates a massive problem of access, especially if you live out in a more rural area.
To fix this, health systems are getting really smart. Paramedics are now trained to read EKGs right there in the ambulance, and if they see a major heart attack, they bypass the closer, non-capable hospital and drive straight to a PCI center. They're building these hub-and-spoke models for super fast transfers by helicopter or ambulance. And of course, they're working to develop new PCI programs where they're needed most.
In this quote, this just nails it. It really captures the whole mission. It's not just about one doctor or one procedure. It's about building an entire system of care that's organized, it's fast, it's standardized, so that every single person having a heart attack gets the best possible treatment as quickly as possible.
We have become unbelievably good at jumping in once disaster strikes. I mean, the speed and the success of PCI is just a modern medical miracle. But as we get better and better at managing the crisis, it makes you wonder, what's the next great challenge? It has to be preventing the crisis from ever happening in the first place. How do we make that final leap from treatment to true prevention?
In the case of a STEMI, it's an emergency. The idea is to open the artery now. Primary PCI is a preferred goal with door to device time less than 90 minutes, less than 124 transfers. Fibrinolysis only if primary PCI is unavailable within 120 minutes, followed by transfer to an angiography center within 24 hours. This is called a pharmacoinvasive strategy. In the case of an NSTEMI, if somebody is having electrical instability, congestive heart failure, cardiogenic shock, they go to the cath lab immediately. If they have stuttering chest pain, dynamic EKG changes, they may go to the cath lab in the next few hours. Otherwise, a delayed strategy for invasive workup could be performed with cooling the patient off for 24 to 48 or 72 hours. Optimization of the PCI procedure involves radial access using IVUS or OCT to minimize stent-related complications. In patients being revascularized for multivessel disease, complete revascularization is recommended to reduce death and MI. For those in cardiogenic shock, routine PCI of non-infarct arteries is harmful. Culprit-only PCI is done to reduce mortality and renal failure. Patients may be brought back at a later date for complete revascularization. The long game always involves secondary prevention, lipid management with high-intensity statin to lower LDL less than 55, addition of Zetia or PCSK9 inhibitor or inclisiran could also be considered. Dual antiplatelet therapy for 6 to 12 months, at least 12 is preferable. Consider tricalagor monotherapy. Additional de-escalation strategies are being considered. Further, cardiac rehab is recommended for all ACS survivors to reduce death and readmission.
You know, some of the biggest medical breakthroughs, the medicines that have saved literally millions of us, they don't always start in some shiny, high-tech laboratory. Nope. Sometimes they're found in the most unlikely places you can imagine, like a little bit of mold growing on some rice in Kyoto, or even just a handful of dirt from the most isolated island on the entire planet.
So that really begs the question, right? Where do these miracle drugs actually come from? Well, today we're going to dive into two incredible and completely different stories that answer that question. And what you'll see is that a life-saving discovery can come from a very deliberate, targeted hunt, or it can be a complete and total, but very fortunate, accident.
Okay, so let's break this down. On one side, you've got the methodical hunt. Think of a brilliant scientist with one clear goal, just relentlessly searching for a very specific key to unlock a puzzle inside our bodies. But on the other side, a fortunate accident. A medical team travels to a remote island for a completely different reason and just stumbles upon a cure they weren't even looking for.
Let's kick things off with the hunt. So, by the middle of the 20th century, the world was facing a massive problem, a silent killer, high cholesterol. And the scientific community, well, they were desperately searching for what you could almost call the penicillin for cholesterol.
I mean, the evidence had been piling up for decades. Way back in 1910, scientists saw that hardened arteries were just packed with cholesterol. By the 1960s, huge studies had basically proven it. High cholesterol was directly linked to deadly heart attacks. So everyone knew the problem. But a real effective solution, it was just nowhere to be found.
And you can just feel the urgency. Listen to this quote from the 1964 Nobel Prize banquet for cholesterol research. You can hear the hope, almost the desperation in their words. They knew they were on the verge of understanding this thing. And the dream, the big dream, was to find a weapon to fight it. They just needed someone to build that weapon.
Enter Akira Endo. He was a biochemist from rural Japan, and as a kid, he was just fascinated by the world of molds and mushrooms. He'd read about Alexander Fleming, the guy who discovered penicillin in a mold, and it sparked this brilliant idea. Hey, if fungi can make things that kill bacteria, why couldn't they also make things that block enzymes inside our own bodies?
Now here's the crucial part. Endo didn't just start mixing things up and hoping for the best. No way. He came up with this incredibly clever, methodical, three-step hunt. He was looking for one very, very specific type of molecule, one that could block the body's cholesterol production line right at its most important step. His whole system was basically a filter designed to find that one specific thing and throw everything else away.
And let me tell you, this was a painstaking search. Can you just imagine the sheer persistence it took? He and his team screened over 6,000 different molds and fungi, one by one. It was literally like looking for a microscopic needle in a haystack the size of a mountain.
After testing 3,800 different strains, they finally got a hit, a compound called citrulline. And it worked perfectly. It blocked the enzyme, it lowered cholesterol in rats. The excitement must have been off the charts. But then, disaster. They found out it was incredibly toxic to the kidneys, a complete and utter dead end.
You'd think that would be the end of the project, right? But Endo later said that this early failure actually gave them the courage to keep going. They knew their theory was sound. They just hadn't found the right mold yet. And then, believe it or not, they did. In a rice sample from a little grain shop in Kyoto, they found a blue-green mold that produced a substance they called compactin.
This had to be it, the big breakthrough. Compactin was a super potent inhibitor of their target enzyme. They gave it to their lab rats, the standard test animal, expecting a miracle. And absolutely nothing happened. Their cholesterol levels didn't budge. The whole project was almost shut down right there on the spot. It felt like 2 years and 6,000 tests had all been for nothing.
So why on earth did it fail? Okay, this is where Endo's genius really comes into play. He figured out that in rats, the drug made the liver fight back by just producing way more of the cholesterol-making enzyme, which completely canceled out the drug. But, and this is the incredible part, he predicted that in humans, that same rebound effect would trigger a different reaction. Our bodies would create more receptors to pull cholesterol out of the blood. The very thing that made it fail in rats was the key to why it would be a massive success in people.
And his theory held up. He tested it in other animals. In hens, cholesterol plummeted by 50%. It worked in dogs. It worked in monkeys. The project was saved from the chopping block. Endo was so confident, in fact, that he was part of the very first totally unsanctioned human trial on an 18-year-old patient with dangerously high cholesterol. And it worked there too.
Okay, let's hit pause on that story of the methodical hunt for just a moment. Because now we're going to travel halfway around the world to one of the most remote spots on Earth for a story that didn't start with a specific target, but with a simple handful of dirt.
Welcome to Rapid Nui, better known as Easter Island. So back in 1964, a Canadian medical expedition traveled there with a really specific question. They'd noticed that the people there often walked barefoot, but they almost never got tetanus. So their whole mission was to figure out why. They weren't looking for a cancer drug or an immunosuppressant, they were looking for an anti-tetanus bug in the soil.
Well, that soil sample contained a bacterium that produced this absolutely fascinating molecule, and its journey has been incredible. In '75, it was isolated and named rapamycin, and at first they just thought, oh, it's a good antifungal. Then years later, it gets approved as the powerful immunosuppressant sirolimus, helping to prevent organ transplant rejection. Then, decades after that, another complete surprise, it turns out it could be a treatment for genetic blood disorders.
And that specific disorder is beta thalassemia. It's a really serious genetic condition where your body can't make enough adult hemoglobin, which leads to severe anemia. But scientists knew about a potential workaround. See, if you could just get the body to start producing more fetal hemoglobin, the kind we all have before we're born, it could make a massive difference for these patients.
And guess what? That's exactly what the drug from the Easter Island dirt did. In a recent clinical trial, sirolimus was shown to fire up the production of that fetal hemoglobin. And here you can see the real-world impact. It reduced markers of red blood cell destruction and iron overload. These aren't just numbers on a chart. These are concrete, life-changing improvements, all from a surprise discovery in some island soil. So, there we have it. 2 amazing discoveries. One from a laser-focused hunt, the other from pure chance. But you know, just discovering the molecule, that's only the first step. The road to actually getting these cures to the people who need them is often just as hard, if not harder. For statins, the path was just brutal. Endo's own company shockingly dropped compactin because of a flawed study that suggested it caused tumors in dogs at ridiculously high doses. It was another company, Merck, that saw the potential, developed an almost identical molecule, and finally brought the first statin to market in 1987.
And for sirolimus, it was just a slow burn, finding new purpose after new purpose for nearly half a century. But the result of all that persistence, it's just staggering. Thanks to Akira Endo's methodical hunt and all the development that followed, it's estimated that 30 million people around the world are taking statins today. It's truly believed that millions of lives have been extended because of this one class of drugs that all started with a bit of mold on rice.
So when you put it all together, what can we really learn from these two incredible and incredibly different stories of discovery?
Well, they show us that there isn't just one single path to a medical miracle. You've got the methodical hunt, which is driven by a clear goal and just sheer relentless work. And then you have the fortunate accident, which is born from having an open mind and the curiosity to look at a surprise and say, huh, what's that? Really, it's a powerful argument that we need to support both kinds of science, the focused projects and the open-ended exploration that leads to discoveries nobody could have ever seen coming. It really makes you wonder, doesn't it? After seeing what was hiding in a Kyoto rice shop and in the soil of Easter Island, you just have to ask yourself, what other life-saving secrets are still out there, hiding in plain sight, just waiting for us in the dirt right beneath our feet?
Adjunctive medical therapies include aspirin, beta blockers, ACE inhibitors, nitrates, statins, and other treatments. There are remaining evidence gaps noted, such as optimal duration of telemetry, definition of transition from acute to chronic coronary syndromes, role of reperfusion late presenters more than 12 hours after onset of symptoms. A lot of research is ongoing to try and address these questions. Thank you for watching. If you want to have more videos made, please drop me an email, ali@aliorg.info.